This first lecture will talk about renal function, and the second lecture will focus on acute and chronic renal failure and dysfunction. The first slide is structure and location of the kidneys, which you can see there. The important part is the functional unit of the kidney is the nephron, shown here, which is also, you can see on slide 3, the different parts of the nephron, which is Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule that empties into the collecting duct, which ultimately ends up in a major collecting duct into the renal calyx and then into the ureters, which drain into the bladder. So there are two types of nephrons. One, this is the renal cortex, and the central part is the renal medulla before we get to sort of that C-shaped part of the kidney bean and the tube that comes out. These shorter nephrons are called cortical nephrons because most of the nephron, pretty much all of it, is only in the renal cortex. The juxtaglomerular nephrons have longer loops of Henle that go into the renal medulla, and they're important in terms of concentration of urine and diuresis. This is the bigger portion of water that we have to worry about, water reabsorption if needed. So we'll talk about that when we talk about antidiuretic hormone. So obviously the job of the nephron is in different portions. We kind of exchange sodium, potassium, calcium, glucose, as well as water, urea, as it goes through the nephron and is concentrated, and the urine will get rid of unwanted materials, byproducts of protein metabolism, and excess water or other electrolytes if needed. Slide 4 is showing you obviously a much better picture of what the renal medulla and cortex look like and how those two different types of nephrons are then situated in the structure of the kidney. There is a very sophisticated capillary system that supplies the nephron. The glomerular capillary system, which will be part of here, that feeds into Bowman's capsule, which creates this very high pressure capillary filtration, favoring filtration into the nephron. And then the peritubular capillary system, which is this part, is just essentially this capillaries that wind themselves around the entire nephron, and that's where reabsorption and excretion between the nephron and the capillary take place. This is depicting, and what the next slide depicts is the interface relationship between the glomerular capillary and Bowman's capsule, and how that whole shape favors the forces of filtration. So off of the renal artery, as it divides down, will be the afferent, or the vessel going into the nephron, the afferent artery, or afferent capillary as part of the glomerulus. It's a little bit wider than the efferent limb of the glomerulus, which is much thinner. There is a knot then kind of capillaries in order to increase the surface area between the capillaries and Bowman's capsule. And that's really depicted much nicer, obviously, than my picture that you can see on slide 6. So you're watching, what you're seeing is Bowman's capsule around that sort of knot of capillaries. The purple cells that you see in between there are called mesangial cells, and they're just supporting this area between the capillaries and Bowman's capsule, kind of a connective tissue. What this is doing is creating high pressure because you can picture this is like a 4-lane highway, and this here, the efferent limb, is like a small frontage road. So you create this big bottleneck of hydrostatic pressure because there's a volume of fluid going in, but coming out is much harder because of the caliber of that efferent limb of the vessel. So we increase the amount of hydrostatic pressure inside the glomerulus, which favors filtration. And the way the interface is it creates these slit pores that makes it very easy to filter fluid through. So here's our vessel here with our plasma, which a large portion of that is water, and red blood cells. And there's a basement membrane between that and the podocytes, or cells of Bowman's capsule, which are these big slit pores that will allow, because we're favoring filtration, fluid to go in to Bowman's capsule. So that whole thing is created to force fluid out. The other part of this, where this glomerulus is located, is something called the juxtaglomerular apparatus, or juxtaglomerular complex, which is a group of cells that are next to the glomerulus and part of the distal tubule of the nephron. And these specialized cells, macula densa, are pressure readers that let us know what is the pressure of fluid inside of the glomerulus. And these are the specialized cells that will help trigger the release of renin if necessary, depending on what the pressure is inside there. So that's how the filtration rate and the pressure inside the glomerulus is where the kidney will then read and decide, is the pressure getting low? Is it that we need to retain more water and increase vasoconstriction? Do I need to activate the renin-angiotensin-aldosterone system? So just like in the first class, if we want filtration to occur, we have to balance the pressure inside the vessel and outside the vessel. So it's the extracellular fluid either in the vessel or in the interstitial space. If the pressure inside the glomerulus, the hydrostatic pressure, is up, and the osmotic pressure is higher in Bowman's capsule, meaning the protein content, or whatever increases osmotic pressure, protein, sugar, sodium, electrolytes, etc. If this glomerular osmotic pressure is decreased, but the water pressure is very, very high, that would force filtration. So the glomerular capillary hydrostatic pressure will force water out of the capillary into Bowman's capsule. The glomerular capillary osmotic pressure is low because that also favors filtration. We want this area to be more concentrated than this area because that means water will be forced out into Bowman's capsule. So if there's any problem, any backup in the nephron where there's too much either loss of protein or there's too much back pressure this way to increase the hydrostatic pressure in here, that would decrease filtration. If there isn't enough flow going into the glomerulus, decreasing the hydrostatic pressure, then that would decrease filtration. And those are actually the two main things. We want there to be very little hydrostatic pressure here and high hydrostatic pressure in the glomerulus. So anything that decreases flow into the glomerulus or causes backup pressure in the nephron will decrease filtration. So how do we concentrate urine and be sure that we lose enough fluid so we don't have edema or problems with excess fluid inside our bodies, but we don't, if we need to save water because the fluid level is going down in our body, how can we control that? And that mechanism is through antidiuretic hormone. So when we did the endocrine lectures, we discussed how antidiuretic hormone is released from the posterior pituitary, and it does just what it says. It decreases the amount of fluid that can be lost in the kidney. So these are the loop of Henle's that are in the medulla of the body of the kidney. They have those very long loops, and they have this long hairpin turn, which creates this interstitial environment between the blood vessel, between this interstitial fluid here and the blood vessel that's also running through in between. So as the fluid up here in the nephron is very concentrated, as the fluid goes down through the nephron, it starts to lose some of its concentrates because those get reabsorbed in the blood vessel that's riding alongside the loop of Henle, to the point where as the effluent, or the fluid that's in the nephron, makes its hairpin turn up this way, the fluid in the nephron is not as concentrated as it is over here. The concentration is outside of the nephron in the interstitium. So by the time this fluid runs down into the collecting duct, it is not very concentrated at all, because some of those concentrates have left there to go into and be reabsorbed by the capillaries. So down this way, there will be a pressure difference between the collecting duct and the interstitial fluid next to this nephron, where the concentration, where the solutes are being reabsorbed. So if this concentration gradient between this interstitium and the collecting duct gets very high, where this interstitium area is extremely concentrated, and this is more dilute inside, that would be a trigger to release antidiuretic hormone, which would sit on receptors, they're called vasopressin receptors, on the collecting duct, and cause movement of aquaporin channels to push water from the collecting duct back into the blood vessel, so that we save the water, antidiuretic hormone, instead of urinating it out. So the key thing is a concentration change between the interstitial fluid and the collecting duct. And the reason this occurs in this spot is because we get this loop around, this hairpin turn, to allow a lot of concentration that was inside the nephron to leave and go to the blood vessel. So we will have created this concentration difference, which is okay to a certain extent, unless it's super, super concentrated in the interstitium. That's telling the body that we need to save more water instead of urinating it. And so we release antidiuretic hormone that opens up the aquaporin channels, so more water goes back into the system instead of leaving in the urine. And once this concentration gradient improves, then that would be a negative feedback mechanism. Pardon me. That would be a negative feedback mechanism to stop the secretion of antidiuretic hormone so that we continue to urinate. The next concept to understand is renal clearance, and understanding how the kidneys will filter a substance and reabsorb it or excrete it. If we know how the kidney normally handles a certain substance, we can predict how much of that substance would be cleared from the bloodstream if the kidneys were working correctly, or there wasn't a buildup of that substance in the body. So typically we talk about the renal clearance of protein metabolism, urea and creatinine, as a way to measure the function of the kidney, which we'll talk about when we're discussing what the BUN and creatinine is. Because if protein is broken down, when we go through protein metabolism, the byproducts of protein are urea and creatinine. Those are normal byproducts. The urea and creatinine gets filtered into the nephron during glomerular filtration, and most of it is supposed to leave in the urine, and only a tiny portion is reabsorbed. The less creatinine is reabsorbed than urea, and so that's why it's a little bit more sensitive of measurement, as well as there can be elevation in urea for other reasons related to other protein problems or other breakdown of other things inside the body. So you could have an elevation in BUN. Oh, there's Kitty. You could have an elevation in BUN because you're breaking down red blood cells means extra protein products in the bloodstream, but the kidneys, especially in the beginning, might be working just fine. So creatinine is a really good way to measure how well the kidney is clearing substances, because pretty much all of the creatinine should be leaving in the urine effluent. Some things that are cleared from the nephrons require transport mechanisms, and if those transport mechanisms get flooded, the urine actually might have an increased amount of a substance in the urine. So we used to always, and you can still see, we used to always monitor blood sugar levels by seeing how much glucose was in the urine. In fact, that's how diabetes mellitus got its name. It actually means sweet urine. So in the nephron, there are transport mechanisms. If glucose leaves during filtration, it should be transported back into the bloodstream and not leave the urine at all, because there are special glut receptors that are located in the nephron. That's our transport mechanism. So glucose and its co-transporter sodium will then go over back into the bloodstream. But we only have so many of these glut receptors. So in normal circumstances, when our blood sugar is normal, we don't always lose a lot of glucose into the nephron to begin with. But if we did, we lose it in such numbers that it can be easily reabsorbed. Because why would we want to lose that? That's our body's fuel. That would be the reason why this transport mechanism was in place. However, if our blood sugar gets too high, then these transport mechanisms on these glut receptors are full. And so we're going to start losing more glucose in the urine. And that's a way where there's a certain point in the blood sugar that we would expect, as it gets a certain level, that you're going to start to lose more glucose in your urine. And that has to do with transport mechanisms. The kidney itself has two different functions, like we've already been speaking about, which is elimination and regulation of electrolytes and pH, getting rid of organic substances and getting rid of the products of protein metabolism. But it's also involved in hormonal action, such as the renin-angiotensin-aldosterone system. We talked about erythropoietin that creates that colony-stimulating factor to increase red blood cell production, and it's a part of the metabolism of vitamin D. So if we want to know how well the kidneys are functioning, we can measure how the kidneys are clearing the products of protein metabolism, since that is one of its main jobs. We could also measure pH. We could measure electrolyte levels, because we know the kidney is in charge of balancing that. But one of the most sensitive ways to tell how well the kidney is working is how well it's clearing substances. So we know that especially creatinine, it's much better at clearing that substance from the bloodstream. It's supposed to nearly completely do that. We can get a little bit of an idea about that from the blood urea nitrogen. So that's telling us how much, when we break protein down, those building blocks, protein metabolism, urea and nitrogen, there should only be so much left in the bloodstream because a lot of the urea should leave through the urine. But like I said, the BUN can often be changed related to fluid balance in the body because just like creatinine, it's a percentage. We expect a certain, or it can be manipulated by the hydration status or fluid status of the body, so I could have a very high BUN, which you might think, oh my goodness, is this patient's kidneys not working? And eventually that might be the case, but it could just be in relation to the fluid in the body, the blood urea nitrogen has increased. So it's not as sensitive to the ability of the kidneys to clear substances than creatinine is. So if my creatinine goes up, well, probably my BUN would also go up. That's telling me that my kidneys are not clearing or filtering the products of protein metabolism as well. And the person will start to get uremia or azotemia, meaning they're getting the byproducts of protein metabolism increasing in their body. And so if they cannot eliminate urea, that will lead to many different types of symptoms that can occur in the body, such as change in mentation, numbness and tingling, changes to the skin. It makes tissue more itchy. The other things, if we know that urinary clearance isn't working as well, we know that our fluid balance will be off. If there's decreased filtration, we're going to have excess fluid in the body. We're going to have excess hydrogen in the body since it's part of pH balance, and we're going to have more potassium in the body because its filtration of potassium is also very important. And we could potentially have issues with blood pressure, red blood cell production, and calcium and phosphorus maintenance because it's part of the regulation of vitamin D. So understanding what the kidney does will tell you how much and how many body systems will be affected by damage to the kidneys at all. So because we expect that the body will eliminate most creatinine, we can use creatinine as an estimate of the glomerular filtration rate. You could actually calculate glomerular filtration rate, which is even more sensitive than the creatinine level. But what this is telling you is if this level goes up, if it doubles, that represents a 50% decrease in nephron function. So it's huge. So when someone gets, if someone's creatinine is usual 0.7 and it goes up to 1.4, that maybe doesn't seem a lot, but it actually is quite a bit. They've lost 50% of their nephrons, either because of decreased blood flow into the glomerulus for various reasons, or trouble with back pressure in the nephron that's not allowing filtration. And that's what we have to figure out is what is the cause. Once the creatinine rises to 3 times the normal value, then we've lost 75% of our renal function. So this number, we have to be very careful and very concerned with even tiny changes in the nephron, in the creatinine, because it's telling us a lot about the potential problems in the kidney itself. So serum creatinine interpretation is different during a chronic steady increase that you'll see related to chronic renal failure. We expect over time, if people, chronic health problems such as diabetes and hypertension, hyperlipidemia, that will decrease flow into the kidneys because of problems with resistance in the vessels. we would expect that over time, unless those problems have changed and the person has gotten control of those chronic health problems, that there'll be a slow march, a slow increase in baseline creatinine, signifying a slow decrease in renal function. And so we would be very careful about that person's kidneys. They're certainly at increased risk of a problem. But if their creatinine is usually normal and they experience an acute rise in creatinine, then we have to evaluate it a little bit differently. I wouldn't expect that to happen. And oftentimes we would have to find the underlying problem in that setting, whether it be that they have a pre-renal, intrarenal, or post-renal problem that's causing their acute rise in creatinine. There are other kidney function tests. The BUN creatinine ratio is very helpful when you're trying to determine if the problem is post-renal versus intrarenal. When there's an acute rise in creatinine, that's when the BUN to creatinine ratio is the most important. You can also see, is there something that's being filtered into the kidneys that's abnormal, which would suggest that there's breakdown of the nephron itself, or is the kidney losing its ability to concentrate urine like it's supposed to, which is why urine osmolarity and sodium concentration can be helpful to measure as well.